We welcome you to the fourth webinar of Smile Train, Cleft Palate and Cleft Lip. I would like Mamta ma'am to please take over.
Hello, everyone. Good afternoon. And thank you for this collaboration, and thank you for, hosting these webinars in association with Foxy and Smile Train. I would first of all like to introduce and pay my thanks to Dr. Rishikesh Pai, under whose leadership all of these initiatives are being carried out. Dr. Rishikesh Pai is the president of the Federation of Obstetric and Gynecological Societies of India, and founder member and medical director of Bloom IVF Group, and holds several positions. The positions which you can see on the screen. He has a very illustrious background. Moving on, the very noteworthy initiatives initiated and led by Dr. Pai is the Badlao Clinic, which is a very unique initiative started under his guidance, and which basically aims at the betterment of women in our country, and the change that it brings about in women's health through the amalgamation of Ekikaran, Samanta, and Technique. Getting all of these three elements together and then packaging up them as Badlao. I think it's an amazing project which has been started and led by Dr. Rishikesh Pai. So thank you so much for that. Moving on, I'd also like to introduce Dr. Madhuri A. Patel. She is the General Secretary of Foxy, and she's the Honorary Clinical Associate at the N. Wadia Hospital in Mumbai, and also consultant at the Police Hospital in Mumbai, besides various other positions and other memberships that she holds, which you can see on the screen. A very special member today is also Dr. Chinmay Rath. She is the Director and Lead Consultant, Fetal Medicine and Resolution Fetal Care Center and Research Institute, also a Senior Consultant at the Yashoda Hospital, Secunderabad, in addition to her holding various memberships and various positions in Foxy. We move on to our very esteemed guest again today, Dr. Sundareshwar Chandra Sood, Dr. S.C. Sood as we call them. He is a plastic surgeon. He's a senior consultant and head of Department of Plastic Surgery. He's a project director at Smile Train, Sant Padmanabh Hospital, Civil Lines, New Delhi. He is also the associate director and head Department of Aesthetic and Reconstructive Surgery at Max Hospital, which is also a Smile Train partner at Delhi. He's been associated with Smile Train for many, many, many years and done several, he and his team, cleft lip and palate surgeries supported by Smile Train, in addition to, doing all the other things that a plastic surgeon does. So thank you, everyone. Thank you for taking out the time and joining us at this webinar today. I will also give you a very, very brief background on what Smile Train is and what do we do. So Smile Train, as you may know, is the world's largest cleft focus organization with a sustainable and local model of supporting surgery and other forms of essential care. Over the last 20 years, we have supported safe, high quality and free cleft surgeries for more than 1.5 million children, and will continue to do so until every child in need with a cleft has access to care that they truly deserve. Our collaboration with Foxy is very, very unique because it focuses on a very critical aspect of our programs. Being the first point of contact for mothers, gynecologists play a very vital role in identifying fetal anomalies and educating families with the right information. Hence, their sensitization and awareness is a priority. Both organizations came together and developed a protocol for early diagnosis and intervention for cleft lip and palate. This, we hope, will drive better surgical outcomes and improve the quality of life and the quality of care for children with clefts. Thank you very much, ladies and gentlemen, for being a part of this initiative, for coming here today and listening to our panel members here today. So thank you very much, and over to Shruti.
Over to you, Chinmay ma'am.
Hello, good afternoon, everyone, and good afternoon, Dr. Sood here. And I thank our President, Rishikesh Pai, sir, and our Secretary General of FOXI, Dr. Madhuri Patel, for having made this initiative possible of all of us interacting at one forum to consider the antenatal as well as the postnatal management of cleft lip and palate. So I actually have a little presentation to make. So if you can allow me to share my slides, I can present that. Can I share?
Yes, ma'am, you can share your slides.
So thank you. And this is... So cleft lip and palate is something which is really close to my heart because we deal with a lot of these patients, and in our state, we have a government-aided program for, managing these patients postnatally. And since I am an obstetrician, gynecologist, and a fetal medicine specialist, I deal with mostly the antenatal paradigm, and that's what my topic is. That how does the antenatal assessment of cleft lip and palate help in the postnatal diagnosis and the workup? So I'll just briefly kind of present my side of the situation, and then I think Dr. Sood can help us with the postnatal assessment of these situations. So we all know that fetal structural anomalies are part of antenatal care, and when we look at 100 babies or 100 women in an OPD, 3 or 4 of them may be carrying babies with congenital anomalies. It's not uncommon. And the diagnosis of an anomaly is actually the beginning of a long journey where we have to sit with the parents, counsel them as to what the situation is and what is the way forward. And if you look at the total prevalence of congenital anomalies in our population, we very much fit into the data that is the world statistics, and the percentage is somewhat similar. In some cohorts, it may be higher because of malnutrition in the mother or sometimes pre-existing medical disorders. And the congenital anomalies have become a very important reason for neonatal deaths. Now, cleft lip palate, one would think, cannot lead to a death particularly because it's not a lethal abnormality. But then feeding of a baby is the most important care that you give in the newborn period. And with a cleft lip palate, feeding itself becomes a challenge. So sometimes because of indirect reasons, cleft lip palate can even become a reason for fetal death, neonatal deaths. And therefore, it's important that we know about this condition well in advance, and we have a plan in place to manage a baby who's born with cleft lip palate if needed. So craniofacial anomalies is the broad category under which these problems will come, and they have significant functional and cosmetic consequences. They are correctable because there is a surgery for this which can lead to a very good outcome. But what is needed is a cohesive multidisciplinary team which can help in optimizing the final outcome. So we start from the very beginning, and that says that there is a very concerted way of looking at a fetus in the antenatal period. And when you look at the fetal phase, there is a checklist for the fetal phase, and that checklist includes the viewing of the fetus in a way that you definitely demarcate the palate and the lips. So these are axial sections of the fetal head and face in the second trimester. And as you can see, these red arrows indicate which sections we are looking at. And if we look at these sections, we can see both the orbits, we can see a clear maxilla and a clear mandible. And this is what is the hard palate with the alveolar sockets there. And this is a normal hard palate. You have a C-shaped palate with integrity intact and the soft tissue over it intact. Similarly, you can do a coronal viewing even in 2D of the fetal face and get the upper lips and the nose, the nostrils seen like this, so that the intactness of the upper lip is completely ensured by the second trimester scan. So honestly speaking, cleft lip and palate must be at least detected in the second trimester. It is not something which you can say, oh, I mean, we can't see it. There may be reasons why they may get still missed, because sometimes fews are not as clear as this. You may be having multiple pregnancies. There may be a triplet pregnancy with multiple fetal parts and some of them causing shadows, and therefore it can be missed. Severe oligohydramnios, where you just can't see every part of the baby's face, may not be in a correct position. There may be a hand or something obstructing the part. But in those cases, the report will then say that the face was not evaluated properly. But if the face is evaluated properly, palate and lips have to be seen, and if they are seen, their integrity will have to be detected. So, I am taking responsibility while saying that with a good anomaly scan in mid-trimester, a cleft of the hard palate and cleft of the lip should be ideally detected. It's very irresponsible to say that we cannot detect it. So there are other problems in the fetal face which may be little subtle, and they may not be very, very clear on the scans. But if you have a cleft, you can detect it. And the prevalence of these clefts is like 1 in 1,000. It's about 0.15%. And antenatal sonography is an accurate and reliable tool to detect these malformations. The problem is when you see a facial malformation, it is just the beginning of the story, like I said, for all other abnormalities. And one has to make sure that there are no other problems, because for every abnormality, the same dictum works, that if it is an isolated condition, the outcome is different. If it is in association with multiple abnormalities, then the prognosis becomes further guarded. So when there is a cleft of the lip or the palate, you have to then counsel the patient. And you understand what a cleft is, but the patients don't. So it's good to give them a visual impression and correlate your ultrasound pictures to postnatal pictures of other patients, or, from the internet, to show them what it is that they are expecting when the child is going to be born. Because the biggest problem in these patients is they get, if it is not detected, they get really shocked to see the child's face, because it is very distorted, and the face is something everybody looks at for the first time. So giving them a visual impression of how this baby is going to look after birth helps in preparing them mentally for what exactly is the problem, because the functional aspect and everything will come thereafter. But unlike a cardiac anomaly, this child will not look like every other child does after birth, and that mental preparedness is very important. And thereafter also, you need to give them little support, that they understand that this is what it is and it gets corrected later on, so they don't get shocked at the time of the birth of the baby. So a detailed counseling is required. Now, in the antenatal paradigm, diagnosis of this is very important. So when we do the ultrasound, you must have clear pictures and you must be able to confirm the site and the extent of the cleft. So there is a known prevalence of unilateral cleft lip, unilateral cleft lip and palate, bilateral cleft lip and palate, and bilateral cleft lip. So it can be in all kinds of combinations. So the lip itself, if it is cleft and the palate is intact, that is a less morbid situation. But whenever the hard palate has a cleft in it, that requires intensive newborn care, and therefore it's very important to know whether it is a cleft only in the lip or it affects the palate. Whether it is unilateral or bilateral will affect the possibility of this being part of a genetic syndrome or a chromosomal abnormality, or just being an isolated structural defect. The unilateral problems generally are isolated, whereas the bilateral ones are generally associated with, coexistent genetic or chromosomal abnormalities. Now, the challenges which are associated with looking at the palate is, while the hard palate is pretty straightforward. There is a bony shadow and you can reach there and see that. Looking at the secondary, soft palate sometimes becomes difficult, and there may be shadows just from the hard palate itself, and detecting cleft in the soft palate may not be the strongest point for an antenatal sonographer, because there are technical limitations to detecting that. So there are new signs that have come up in detecting the clefts of the soft palate also. While the hard palate can be seen very easily on the regular ultrasound, for soft palate we look at some extended signs, and for that we look at it's called the equal to sign. I think we'll come to that. And this is again something which I want all of you to understand, that there could be a false positive diagnosis of cleft sometimes, because antenatal ultrasound, when we show in the pictures in the conferences, we take our best pictures, we take the best views, and we show real clear pictures. But life is always not that simple, and there is always artifactual problems. And especially in lip and palate assessment, if there is an umbilical cord right in front of the fetal face, very often we get a distorted image even on a 3D, and we can mistake it for a false positive diagnosis of a cleft lip. Palate, it's a little difficult to have a false positive diagnosis, but mistakes can be made at any time, and that will be a mistake of interpretation. And therefore, every sonologist must make an attempt to get a clear view. When you see the orbits and just go down and see the palate, it is unlikely you will make a mistake. But if you are somewhere, oblique, and you're trying to see it in a different way, you may mistake it for different bony gaps and think that that is a palate. So there is a possibility of having a false positive or a false negative diagnosis of cleft lip and palate. But if you do it correctly, my point is you will minimize the errors. So when you see the palate, it is good to see the complete extent of the palate, because sometimes there may be little defects at the edges, like you see here. It's a very, very lateral kind of cleft in the lip and the palate, and if that is seen, that also needs to be understood. Here, in the first trimester, it's a very, very small baby. The baby is between 4 to 8 centimeters, and one may miss this kind of a problem. So 100% diagnosis is not always possible in the first trimester, but there is a possibility to look at some signs which indicate a higher risk of having a cleft in the palate. For example, in the first trimester, when you look at the fetal profile, you see the vomer and the palate separately, and there is something called a superimposed line. So when we don't see that second line and it looks like a single line palate there, we can suspect cleft palate. Similarly, there are these bony margins in the first trimester representing what is called as the retronasal or the premaxillary triangle. And if it is completely intact, then the palate is expected to be intact. Whereas if the base of this triangle is distorted, then again we suspect cleft of the palate. The maxillary gap sign is another sign in the first trimester, which helps us suspect cases of cleft palate. So in the first trimester, if we can get a clear picture of all these things, the likelihood of clefts in the palate will be less. If we are very, very sure that there is a cleft, we can declare it. But sometimes it is prudent to tell them that, we are suspecting, and we will keep a follow-up and see this in the second trimester. If it is confirmed in the second trimester, then it is unequivocal in terms of diagnosis, and then we have to start the process of counseling the patients about how to go ahead with this diagnosis. So a detailed explanation of the problem is important, telling them that there will be extra, inputs in terms of feeding, which will be required in the newborn period. And then there is a pathway towards surgery, which we will have in the next session. It is a potentially correctable abnormality. If we suspect that this is not just an isolated problem, it may be part of a bigger syndrome, then offering them an amniocentesis to check for the fetal chromosomes or a microarray in the prenatal period is not unjustified. It also helps allay some degree of the anxiety that this is an isolated problem. And it is a good idea to meet with the pediatric plastic surgeon at this point so that a continuity of care can be established. They may not be operating at this point, but if they talk to the parents, it makes a lot of difference for the parents to understand the situation. And that is what I wanted to say is the changing paradigm in antenatal detection, that we make the pathway for postnatal correction smooth by starting the process of the pediatric consultation at this point. So in our city in Hyderabad, we have the Nizam Institute of Medical Sciences, and Dr. Parvati heads the plastic surgery department there, and she takes care of this cleft lip palate correction unit, and they provide free surgery postnatally in addition to some kind of transport allowance to the parents. And we've had an extremely good experience with sending patients there, because you may think, oh, it's a government organization, people will care or not care, but there they give individual care to the patients, and they do counsel them with good visual aids. They have actually shared this with us also, where they give them not only a timeline of when corrections will happen, but also what is the result of the correction and speech therapy and everything. And from the time we've started sending our patients to that unit, we've realized that our continuation rates of cleft lip and palate have actually improved a lot. So identifying the problem is one thing, and giving them a pan. What they ask us is the details of whether the lip or the palate is involved. Can you measure the gap and tell us how much? If you can, look at the soft palate also. Soft palate is a little difficult, but there is this equal to sign which we see in the pharynx. And if we are able to see that, we can tell you at least that the soft palate is intact up to that extent. So diagnosing the condition prenatally is one thing, and setting up a multidisciplinary team. So in addition to the neonatologist who will take care of the immediate feeding issues, you have the pediatric plastic surgeon who will take care of the complete, care thereafter. There are specialized nurses who take care of the feeding problems. So if the patient has to deliver in some other far off place, if you saw the timeline of that surgery, everything starts many days or months after birth, and therefore one need not have to deliver in a tertiary care center just because of a cleft lip palate, and they can deliver in their own districts, and they can be given occluders and taught how to use them by specialized nurses, so that they can palliate the problems till the corrective surgery is taken care of. So it's a lot of teamwork, and in postnatal period there's even more intensive teamwork. So it affects every function of the face in some way. So what we want to do is tell the patients that, you expect this problem, but there is a correction available, to make them feel less conscious about it. After COVID, many people started using masks all the time, but we used to advise the couples that, when the child is born, keep the face covered with a mask, so that everybody who sees the baby doesn't, jump off and say, oh my God, what's wrong with this baby? Because sometimes people are not sensitive and they comment on these things, and the parents get very disheartened. So it's important to give them these kind of minor lifestyle modification advice, and then they can take it forward happily. A multidisciplinary team can be instituted well in advance in the antenatal period, so that it works smoothly in the postnatal period and the patient has a continuous form of care in that transition. Surgery can be done at 3 to 6 months of age, and there is a general consensus, that when palatoplasty must be happening, and I will not dwell into it because we have a specialist speaking on it. So the answer to a crisis in pregnancy is not to eliminate the pregnancy, it is only to eliminate the crisis. And this journey is a long one. It begins with diagnosis of the problem. And here I would just like to put a word of caution to my friends who do prenatal scans. Don't start your scan like a PR exercise. Nowadays, there is a lot of this 3D, 4D thing, and everybody thinks 3D, 4D is only about showing the fetal face. Whereas 3D, 4D is much more than that. Actually, showing the fetal face is kind of abuse of that 3D, 4D technology. But while it's nice to see pretty faces, if there is a cleft lip or palate, that whole exercise can turn into a nightmare if you started it with that purpose alone. So start every scan as a medical procedure. Make sure things are good before you start calling the parents in and showing off your new technology. Good pre-test counseling prior to the scan and information leaflets after the scan help in taking the findings of the scan to a logical conclusion. The antenatal counseling for any fetal anomaly is to prognosticate it, plan antenatal care, because women who carry fetuses with cleft lip palate may then develop polyhydramnios because the fetus does not swallow that well as a fetus with normal lip and palate does. And therefore, the delivery can be preterm and adequate precautions have to be taken. You have to plan delivery properly. It need not always be in the tertiary care center, but it has to be in a center which is prepared for all these problems. Neonatal care and follow-up. And sometimes you may need to counsel them over and over because it overwhelms them. So whatever they've accepted today, after a few months, they may still get jittery if something else happens. Some of these babies develop growth restriction and then the whole prognosis changes for them. So it's good to keep in touch with them, explain to them that this is a dynamic issue and things keep changing, and be of support. Because every time they say, can you give us a guarantee for everything? So the answer always is, as a perinatal team, we cannot guarantee that we will cure everything. But what we can always guarantee is we can certainly care for everything. And with cleft lip palate, that really works well because you tell them that, we have a system to care for you and we will support you throughout. You just have to walk with us and we will take you to a logical conclusion. With that, I will stop my presentation. Thank you very much for a patient hearing.
Thank you so much, ma'am, for the wonderful session. There are a few questions from the audience. There's one question from Ms. Nisha from Nagpur. The question is, how soon after the cleft palate surgery should the speech assessment be done?
After the surgery, when the speech assessment should be done, I think that I will leave to Dr. Sood to answer because they deal with it thereafter. So what is the ideal time to deal with it? I think it's better that it's answered by the person who does the surgery. Sir, would you like to take that question?
The time at which we evaluate speech is the time when the earliest the kid is grown up to sit and talk to you and follow your commands. Because speech evaluation means that you ask the child to do something, that's to speak particular kind of words. And you need to, if you need to start speech therapies, for example, you need a child who can follow what your instructions you're giving to the child. So 3.5 years is roughly when we start working on it. Sometimes it does happen at 3.5 years, the kids are not cooperative, so then we wait a little longer. But mostly 3.5 to 5 years is the time when we try to catch these kids. In general, the earlier the better. Right.
Thank you, sir. I think there's a question that's come into my chat there. How can we better manage cleft patients? So I think that's what I was trying to tell, that, you diagnose it early and establish a team together. And in fact, recently I had the privilege of being part of the Indo-Cleft Con, which was held in Belgavi. And I was really touched by the fact that they invited the children who had cleft lip palate repair. And they were part of the inaugural ceremony where they danced and spoke and even sang for the audience, which was very heartening because that's how you help them. You give them a positive motivation and show them how something which can be disastrous can be changed into something positive, and you motivate the parents to accept the so-called deformation and turn it into a win-win situation. So, in fact, in the days and times when it was not diagnosed antenatally, it was anyway treated postnatally. But now that we diagnose it antenatally, I think we create a kind of fear psychosis. And it's unfortunate that some of them actually get terminated also. But we can best manage them by improving our own skill and expertise and outlook. Thank you.
Thank you, ma'am. There is one more question from Ms. Neha from Delhi. The question says, can you tell that a cleft palate will always result in a cleft lip also?
Usually the association is like that. It's usually that the you very seldom get isolated cleft palates. You can get an isolated cleft of a soft palate for sure, but the isolated cleft of hard palate is very, very rare, but not unknown. So the ideal method, and in fact, the caveat here is it's easier to detect a cleft of the hard palate. What you can miss is a cleft of the lip because of it being a soft tissue and it getting distorted by artifacts and tissues. So it's not impossible; it is possible. And the ideal way to image a fetal face in second trimester would be to look at both the integrity of the upper lip as well as the integrity of the palate, hard palate.
Thank you so much, ma'am. Over to you, Dr. Sood.
Sure. Yeah, are we good to go? Yeah. Good evening, everybody, and thanks for having me here. It's great to see Smile Train and Foxy coming together to help these cleft children. And it's a great opportunity for me to talk to the obs gynae people because they're the first people who come in contact with these children. And obstetricians and gynecologists normally are like family friends to a patient, and so very often they trust them more than what they would trust me, with a 5-minute consultation or 10-minute consultation, they'll have me. So cleft lip and palate has made a lot of, progress in last 10 to 20 years. And one big reason all that has happened is because like in West, the centers are doing very small numbers. And with organizations like Smile Train stepping into these things, now the centers are developing where there are large volume cleft surgeries being taken place. So it gives a greater opportunity for surgeon to see his results and then to improve. In general, all the progress, the two basic things which have changed in last 10 or 20 years is that now our approach is 4-dimensional. Previously we used to reconstruct a lip or a palate and we'll see that it looks like normal or it functions like normal. So that's a 3-dimensional reconstruction. But now there is a 4th dimension because now we realize that so much we do at the age of 3 years to 1 year's lip and palate surgery actually determines what's going to happen at 17 years of age. So the 4th dimension is the time, the age. So it's there, you have a kid who is 3 months old with a lip surgery looking pretty fine, but there would be something in the technique which will determine how the jaw will grow and how nose will look like when the kid has actually grown up. And secondly, what's been done by Smile Train to a large extent to all its cleft centers is to emphasize on comprehensive cleft care. So previously it was just surgery. You have a cleft child referred to surgeon and that's the end of the story. Now it's far more than that. Now it's a team approach. And that team approach involves an orthodontist with need a speech language pathologist, a social worker, a psychologist, and all these people working together on this patient. And that has dramatically changed the end result that patient gets. Soon after birth, the first thing to deal with is breathing. Normal cleft palate patient would have an open airway, right? So he has more airspace than a normal person would do. So the breathing is not an issue. But there is a subgroup, which is called Perry-Robin sequence, which has specific breathing problems at birth. Perry-Robin sequence is a situation where the jaw is small. So the patient has micrognathia, and the tongue is large for the mouth. So there is macroglossia, and it's more posteriorly placed, thus obstructing the airways. In fact, what we believe is that it's because the tongue is large and posteriorly placed that the palate has failed to fuse and a cleft palate has resulted. So this is one situation where we need to be actively involved in managing the airways of the children when they're born. Most of these kids will respond to prone positioning. As you keep the child prone, the tongue moves forward and opens up the airway. Sometimes you'll need a nasopharyngeal airway or nasal CPAP. Very occasionally, you'll require an intubation or more invasive thing. But once you require, then these are the kids who have major problems, and they will also end up with surgical corrections, which might be in form of tongue-lip adhesions, where you join the tongue with the lip, thus keeping it more anteriorly placed, or mandibular destruction, where you cut the mandible and you move the fractured segment or both sides of the mandible apart, thus moving the tongue more anteriorly. Occasionally, as an emergency measure, one would need a tracheostomy. Good thing we need to know about peri-Robin sequence is that it's time-bound. It's not something which the child is going to live for a lifetime. As the child grows, mostly in few months, year or year and a half years time, these symptoms, they wane, and subsequently the child is going to have a normal growth. In fact, most of these kids will have a normal sized jaw when they grow up. Second most important thing soon after birth is how to feed. And this is probably going to be one of the most important messages today in my presentation, because so many children, for just the want of a proper advice, stay malnourished in our country. And when they're malnourished, not only they are prone to so many other problems, but all the surgeries get delayed. And delayed surgery means an inadequate result to a surgeon as well. So we need to work on feeding these children these days. And all you need to do is give a good advice at that particular moment. So let's first understand what are the problems with the feeding. Now, the basic one problem in cleft lip would be there is no lip seal. So when the child sucks on a nipple or a mother's breast, the lips, they seal the area so that the child can create a vacuum. So in isolated cleft lips also, there'll be an issue with the feeding. But in an incomplete cleft lip, that's not an issue. In a complete unilateral cleft lip, all you need to do is to place the nipple on the contralateral side of the lip. This will allow the child to have a seal and feed normally. But in bilateral complete clefts, again, there might be an issue, and the mother might need to express some milk and put it in child's mouth so the child can swallow. Second problem is with the palate. Now, the second step in feeding of a newborn is to suck, to create a vacuum or a suction thing in his oral cavity to get the milk in. Now, this is obviously deficient in cleft palate patients because there is a gap on the top which opens into the nose. And the third step in the deglutition in this process of swallowing is to create a bolus of the feed, which the soft palate would push into the esophagus. This bolus keeps the air separate from the food itself. Normally, when we eat, we do swallow a little bit of air. But since in these children that is defective, a lot of air gets swallowed. So lip seal, we have already talked. All we need to do in unilateral lip is to put the nipple or the breast on the other side. In cleft palate patients, nasal regurgitation is a problem. Swallowing excess of air, as I told you, is a problem. And this excess of milk tends to get into air passages or the ears via the eustachian tube. Eustachian tube function is also abnormal in these children. So these children become more prone to upper respiratory tract infections and ear infections. So 3 basic principles of feeding these cleft palate children, no matter what device you use or what you do. Number 1, keep the child upright. Keeping the child upright would mean that the feed will not get into the nose. So nasal regurgitation would be less. Secondly, put only that amount of milk into the child's mouth which child can swallow comfortably. This amount will be significantly less than what a normal child can swallow. So less amount of milk, and the mother is the best judge. So you need to know how much milk is going inside the mouth, and the mother needs to check it every time that this is the amount of milk that's going on, and this is the amount of milk which the child will be able to swallow normally. And as I said, these kids swallow a lot of air. So frequent burping, after like 3 or 4 or 5 spoons of feed, take a pause, burp the child by keeping its head on the shoulder and patting the back. and then feed a little more. So the feeding has to be a very slow process with frequent burping in the middle. Breastfeeding is, of course, promoted, and the best way to breastfeed is to take one of these two positions where the child is upright, and then mother can put some pressure and squeeze her breast and express some milk into the child's mouth. It's good for the bonding between the mother and the child. So it's encouraged, but the mother again needs to be very careful about the amount of milk that's going on. And not all patients or all mothers are able to continue this for long because of the total ability to express milk and for the inability for the child to suck. Spoon feeding is something which I advise very often. And this is one good thing because the mother gets to see the amount of milk in the spoon, and the child is made to sit upright, and that milk is delivered into the child's mouth, and child swallows it. And these days, you have a bottle with a spoon attached to it, which makes the feeding easier. It's less of an effort on mother's part to feed. So that is something which I prefer. These two bottles are very popular, in cleft children and have been very often advised by many people. One is a regular feeding bottle where you make the hole bigger. And the second is what's they call as a long nipple, which expresses the milk into the pharynx, bypassing the oral cavity. And both of these bottles, the basic issue I have with these bottles is that you can't control the amount of milk going on inside the mouth of the child. And that long nipple delivers the milk right over the posterior pharynx. When you deliver the milk in the mouth, the contact of the milk with tongue and oral cavity allows the child to adapt to the feed. The child knows. Now, if this is a continuous drip in the pharynx, then I'll be concerned. Fortunately, both of these bottles are now available with a one-way valve. That makes them significantly better. And then, because mother squeezes the bottle, it's a soft bottle, and amount of milk will cross the valve and will be seen in the nipple. The nipple is transparent, so you can see the amount of milk in the nipple. And so again, mother will know how much milk is being delivered, and then that milk can be easily delivered into the child's mouth. The middle part of the face, now talking about the next step in management, which is what we call as pre-surgical orthopedics, more commonly known as NAM or nasoalveolar molding. So what's happening is that the middle part of the face grows faster than the sides of the maxilla. So when they fail to fuse both in unilateral and in bilateral clefts, you'll find that there is a disparity in the level of the bone on both sides. Now, this disparity also stretches the nose and distorts the nose. In the first few weeks, first 6 or 7 weeks after birth, there is maternal estrogen in the child's blood, which makes bones very soft. And it's in these weeks, if we start this treatment, which is called nasoalveolar molding, which is a device like this, which an orthodontist will make and will put in the mouth of the child, both the bony segments can be brought to the same level and the nose can be stretched so that it becomes easier for surgeon to repair that. Now, if you look at the picture on the left side with the picture on the right side, both the bones have come to a level and the nose looks less distorted than it was initially. This makes the surgeon's job easier, and there are a lot of studies which show that long-term results are far better if you use NAM. So after these first few things are over, now child is feeding normally, the breathing part is taken care of, and the nasoalveolar molding is done. This is a list of treatments the child might require in his or her life. It seems to be a long list, but remember, not every step is required in every patient, right? Even the worst cases will need probably half of these things, not all of these things, because the modern treatment has so often, as I said, the fourth dimension, taken care of things what are those which are going to present when the child grows up at a later date. Nonetheless, we'll talk a bit about all of these things. Lip repair normally at our center is done at 3 months of age, and the child needs to be a good weight. Normally, a male child would be around 5.5 kgs by that age, and a girl child would be around 5 kgs. Lip and nose are corrected together these days. Some surgeons prefer nasal conformers. These are devices which the surgeon gives to the child or to the mother to use on the child's nose after surgery, which keeps the nose in shape in first few months or after surgery, which makes long-term results better. But nasal conformers are individual preferences. I, for myself, do kind of repairs where I don't use nasal conformers, but a lot of other surgeons use them. So that might be advised to your patient by the surgeon after surgery. So you should be aware of that. Now, cleft palate repair has changed dramatically over last, I guess, 10 years or so. In fact, there are changes which taking place very fast. So we operate these patients from 7 months to 1 year is the age. 9 months is what we prefer at our center. Now, the palate surgery has two important things it deals with. Now, both things are going to happen later. So what you do at 9 months will determine how good the child is going to speak at 3.5, 4 years of age. What you do at 9 months is going to determine how good the face is going to look when the child is 17 years of age, because surgery has an implication on growth of the upper jaw. So a lot of people, have now changed their techniques, and there's a lot of research going on in this direction. Unfortunately, there are few surgeons who are still doing traditional things. So that change needs to happen here, because it's fine, you repaired the palate and looks good, and the mother and parents are happy, and they don't know that what's going to happen later to that child is actually determined by what the surgeon has done at that particular moment. So then we do these surgeries, which are called preschool surgeries. They're basically revision surgeries, and all of them might not require them. But the whole idea is that when the child is like 4 or 5 years of age, and that's the time when the child is going to go to school and interact with other children of his or her age. And children are like, they are innocent guys, so they can make fun of other children without knowing the implications. So this child, which has a deformity on the face or has other issues, and goes to the school and gets, and other children, they laugh at him or ridicule him, that's a time where he loses a lot of self-esteem, and a lot of psychological issues, they come up as the child grows. So revision surgeries before that age, if there is anything that surgeon can do to improve the appearance of the patient, that is the time to have a good look at it. And small corrections like these are all pictures of cases I've operated between last 1 week, 10 days. So you can see the stitches and all that stuff, but then you can see how dramatically so this nose was treated at the time of lip, and by our standards, it's a fairly good result. But the nostril on one side was distorted, so it was corrected. And these kind of corrections are required, and we call them preschool surgeries, and should be done before the child actually goes to the school. Then next part of the treatment comes at 9 to 10 years of age. Oh, I think I've skipped this speech part. Okay, I'll just mention about this speech. So 3.5 years and 4, as I've already said, is the time when you evaluate speech. So speech evaluation is, I'm sorry, I don't have a slide for that, but I'll talk to you about this. Now, speech evaluation is the function of the soft palate. When a person speaks, the soft palate moves posterior superiorly and closes the nasopharynx from the oropharynx. So this whole process allows the air to come into the oral cavity, and then with the help of tongue movements and lip movements, you can change that throat sound into various kind of sounds we produce when we talk. When these children born with cleft cannot pronounce those sounds, they nevertheless try to learn them. And then as they learn them, they try to improvise. put the position of the lip or the tongue differently in an attempt to produce that sound. So speech, as you understand, is a reflex phenomenon. When I'm speaking to you, I'm not thinking how I'm going to move my tongue or how my lips are going to move or how my soft palate is going to move. It happens reflexly. This is something I learned at that age and it's staying with me. And speech is something which we learn only when we're young. As we grow up, our ability to learn speech would be very less. This is what very often I talk to my patient and I said, okay, fine, if I send you to US, will you be able to speak English with an American accent? And he says, no. But if you were born in US, you would be able to? Yes, because as you grow older, your ability to learn speech goes down, down, and down. That's the reason I said that the earlier we catch hold of these children, the earlier the better, right? So common investigation done, two common investigations done these days to evaluate speech. One is called video fluoroscopy, which is kind of an X-ray, where you can see the movements of the soft palate as the child speaks. And these days, fluoroscopy as such is not normally available in X-ray rooms. It used to be there earlier on when they used to do that barium swallow and all that under fluoroscopic control. But, you can do it in a cath lab or you can use a SIAM in the OT and do it, which is what we do. So video fluoroscopy is one thing which helps you to see how much gap is staying there. And second is the nasopharyngeal endoscopy, for which you need a slightly older child where you can put an endoscope into the nose and actually see the gap and plan your surgery accordingly, which way it has to go. So speech evaluation is very important, 3.5 years of age, where you might need another surgery to correct that. And following that, once the surgery is done, so many times parents will come and, okay, you say the surgery is fine, but the child is speaking the same. The child is speaking the same because child has developed that habit, because that's what the child has been doing. So now you need the child to sit with the speech language pathologist, who will tell the child how to use his tongue and the lips to actually produce a sound which he needs to do. And that makes a dramatic difference. So there are various kinds of surgeries which are done for speech issues. We call it that velopharyngeal deficiency is the term we use. Velopharyngeal insufficiency is the old term which some people use even now. So VPR or VPD is one thing we look at, 3.5, 4 years of age. And the treatment now has changed so much that if I take 100 patients, maybe 0.5% or even less of them would ultimately end up with speech issues. Otherwise, most of these children will develop very good speech, provided they follow the timeline. Most patients who have grown up and have speech issues, or they either did not have the right kind of palate surgery, which is true because these surgeries did not exist 15, 20 years back, or they were not popular. So a lot of children at that time, I was doing a different repair 20 years back. So all these things those kids have grown up without the benefit of modern surgery. So they have speech issues, or who do not come to us right age. There's a good palate surgery, there is a speech problem, but the child ends up with you at 15 years or 20 years of age, and parents didn't bring them to you. So that is very important. That's where counseling and information is important. And that's why we are all talking about this today, to have that information so that patients can be guided into the right thing. So that much about speech. Around 9 to 10 years of age, that is the time when the permanent dentition has come up. And that's the time for orthodontics. And orthodontics is very important. It's very important. It's again age related. The earlier you start, the easier and the shorter time it takes. The later you start, it takes a longer time, because the bone becomes more rigid and it's more difficult to change the position of the teeth in that particular person. So orthodontics has to be emphasized. It's a very important part of the treatment. So you can give an excellent lip result, you can have an excellent nose, your cleft palate patient can sing songs and do everything, but the moment he or she smiles, the whole secret is given up. That's where you know that something was significantly wrong with this child. And look at the amazing results these orthodontists can give. These pictures, by the way, have been provided by the orthodontist who works with me, Dr. Puneet Batra. So these are pictures provided by him. During the orthodontic process, in the gap, the bony gap in the cleft, sometimes the orthodontist will request a surgeon to put some bone in that area so that tooth, which was supposed to erupt in that area, can now be moved into that area, so that, and it's mostly a canine which is at the margin of the cleft. So they help that canine to take its normal position once you put some bone there. So alveolar bone grafting is a surgery which we require at this age. So that needs to be done, and that needs to be taken care of. Okay. 17 or 18 years of age, when the dental problems persist in these patients or who haven't had good orthodontics, or some patients, the growth is not complete. So then you require jaw surgeries. In this picture, you see that there is a gap. And it's a gap. It's too late for now for us to fill it with bone and bring a tooth in that area. So what we have done is we've cut the jaw, the maxilla on that particular side, and moved the maxilla forward to finish that gap. So now the dental appearance looks much better than it was earlier on. So jaw surgeries or orthognathic surgery is something which is also required at 17 years of age. Then once the growth is complete, you require other procedures in some of these patients, maybe not all of these patients, like rhinoplasties. These are patients, the first patient was operated by me like 4 or 5 days back. So you still notice a bit of redness and swelling out there. And the second patient was operated by me 15 years back. So these are there. And this is again a case I did very recently. You look at the lip. The central part of the lip is deficient. This is a grown-up girl. And so we have moved tissues and we've added tissue to the central part of the lip. And this is again on-table pictures of a recently operated patient. So you see that fullness in the central part of the lip has appeared. This patient is due for a nasal correction 3 or 4 months later. So we've done the lip first, and now in due course of time, we'll take the nasal thing. So it's an effort which is worth making. It's an effort which will change the life of the patient. And I can proudly say that all patients who stick to us, who follow us, and get the right treatment at the right age, or not us or any Cleft center where all comprehensive care facilities are available, these children are headed for an absolutely normal life, whether it's the appearance or it's a speech or whatever. There are a lot of other procedures I'm not talking about, which we do when these kids get up. Like you can hide a scar with a hair transplant. You can do a lip augmentation to make lip more pouting and look aesthetically more pleasing. Add all aesthetic surgery procedures to make these children look better. So all that have not been included because not typically Cleft surgeries, but they can be offered to these patients to make them look better. I think that covers more or less everything. So thank you very much for your time. If there are any questions, I'll be happy to take them.
Thank you so much, sir, for this session. So we do have a few questions for you. The first question is from Dr. Pratiksha from Kathmandu. The question says, how many surgeries is average to correct the palate and make it not so noticeable?
The palate. We're talking only about the palate.
Yes, sir, the palate.
Okay. So see, in 95% of patients, one surgery should be enough, right? And there are 2 post-operative problems which can happen in palate. One is having a fistula. Fistula is that 1 or 2 stitches give up and you have a remaining hole which stays in. And this hole you'll fix 6 months later. So that's one reason you might have another surgery. The incidence of fistula would be, I guess, under 5% in most of the series, which is, we're talking about posterior fistulas. Anterior fistulas in the alveolar cleft stay very often, and if they're asymptomatic, we ignore them till the time children grow up. But symptomatic fistula would be less than 5% of the total incidence. So that's one reason. And second reason why palate surgery might need to be redone is because of VPD, as I said, if there are speech issues, which will happen in 5% patients at 3.5, 4 years of age. And there are various procedures, like you can take buccal mucosa to lengthen the palate because palate is short. And because it's short, it cannot move back and close the nasopharynx from the oropharynx. So you can increase the length by adding tissues. You can dissect the muscle and make them tighter, so they're easier for them to move and close that mouth. So all these surgeries are now done routinely and around 3.5, 4 years of age. So these are the surgeries these children go to. 95% children, one surgery is sufficient.
Okay, thank you, sir. There's one more question for you from Dr. Abhilash from Kerala. The question is, what to expect exactly after a cleft lip and a palate surgery?
Okay, so lip and palate surgeries are different procedures, right? And so lip surgery is normally, pretty okay things, like you operate the patient in anesthesia, and it's under anesthesia these days. We give blocks with long-acting local anesthetics, so which keep the area numb in the immediate post-operative period. And feeding is normally not much of an issue. Normally by the second day morning, these children are feeding normally, and you can send them home one day after surgery. Few children will stay a day longer, but most of the children will go back home. Palate is another story. Palate is a different story because when the child swallows, the whole area on the inside of the oral cavity has been operated on. So swallowing takes little longer. So these children, they take like 2 days to 3 days to start their feeding normally. And then there have to be strong feeding instructions which have to be followed, like they're on liquids, they're on spoon feeding. And those things have to be done for 3 to 4 weeks to ensure, palate repair is a repair in the ear. There is nose above and oral cavity below. So you're creating a partition where there is free space on both the sides. So a little bit of push can open the stitches and you can have a fistula. So yes, repair needs to be strong, which is what we try to do. But the patients also need to take care of that nothing goes into the mouth, and then there is a spoon feeding. So all those instructions, they stay for 3 to 4 weeks. I guess that answers it. Yeah.
Thank you so much, sir. Over to you, Mamta ma'am.
Thank you very much.
Thank you, Dr. Chinmay. Thank you, Dr. Sood, for such an informative webinar. As always, we have a lot of participants today. We have, members of FOGSI. We also have Smile Train partners and the Smile Train teams who have really, I'm sure, benefited from all of the information that Dr. Chinmay gave and Dr. Sood gave. So we look forward to these webinars, as a series and as a sequence as we work together for the protocol that Smile Train and FOGSI have developed, with our partnership. So thank you once again. And we will be, the next phase is we will be developing, materials and resources for distribution as well. Because just to talk about these things and not kind of follow up with an action plan, I think is like work half done. So therefore, we will be developing, we will come back to you. We will actually form an expert panel where we will circulate drafts of such resources so that your, FOGSI experts as well as Smile Train experts can both collaborate, come together and develop these resources so that we can distribute also. So people have like a ready reckoner or something that they can refer to while, they are either talking to parents, talking to mothers, or, post-birth, they would want to pass on more information about how to handle, these cleft lip and palate children and these cases and refer them to Smile Train. So thank you very much, and we will follow up with the next steps. Thank you so much.
Thank you.